Good morning to all. I think today's speakers need no introduction as we have done that in last session. So I think without wasting any time, I'll hand it over to Sunil first or Theo. I think Sunil is going to present and then case will be done by Theo. That's right?
No, Priya.
Okay.
First of all, we would like to share our plans. So Theo will
Okay.
be going first.
Okay.
So he will be giving some theory and he will be presenting some patient stories also, how to convert
Okay.
some practice session. And then we will have a doubt clearing session. And if time permits, we will again have some cases also.
Okay. So do you want me to give you time check
Uh,
in between?
Yeah, definitely.
Okay.
So
I'll
we would
I'll
like to
uh,
finish by 8:30 itself.
Yeah, so I'll let
So
you know by 7:30,
yeah,
8. Yeah, okay,
yeah.
over to
Thank
you.
you, Theo.
Great, thank you. So last time we spoke, we kind of talked about some of the pharmacology and concepts and monitoring parameters for methadone, and I know everyone was excited with questions on how to do calculations. So today's session, I'm planning on doing that and also doing some practice cases with everyone. So with today's session, everyone attending should be able to identify monitoring parameters for safe use of methadone, create safe, effective therapy plans to initiate methadone, and then also developing safe and effective plans to titrate and adjust methadone doses. So before we jump in, just for a really brief, quick overview of what we went over last time, the key things I wanted to keep in mind is with using methadone, between IV and PO, there are going to be different conversion ratios. If your institution has both formulations, whenever you're switching from oral to IV, you want to half that dose. But if you switch from IV to PO and get patients ready to go back to the outpatient setting, then it's a 1 to 1.2 ratio. And then the complexity with methadone is its biphasic distribution, and its general half-life is on average around 22 hours, but can be longer in various patients, especially those with hepatic impairments or some patients with advanced age. And when we dose methadone, we want to keep in mind that its analgesic effects after repeated dosing can last 8 to 12 hours. And that is varying from the chemical half-life. So another quick concept I wanted to go over is steady state.
Dr. Theo, just want to intervene. We can't see
Yeah.
your screen properly. We can only see half part of it.
Oh,
Theo, please put in presentation mode.
let me. Of methadone going from oral to IV, it's 1 to 0.5, so you would half the dose. And then when switching from IV to PO in instances when you're getting patients ready back to the outpatient setting, it would be a 1 to 1.2. So always remember it's a conservative conversion. And that's because the impacts can be variable for patients. So we can always titrate up, but we always want to be conservative. And then in regards to the half-life and timing of methadone, it does have a longer half-life due to that biphasic distribution model where it gets absorbed. And even though it can be cleared in the plasma a little longer, there is going to be deposits into the tissue. So on average, it's around 22 hours up to 60. And patients with hepatic impairment can actually have a half-life of up to 120 hours. And then keeping in mind that the analgesic duration after multiple doses is 8 to 12 hours and is not necessarily the same as a chemical half-life when we would think of other opioids. So the one brief concept I also wanted to touch upon too was the concept of steady state. So I don't know, I'm sure everyone is familiar with this, but I just wanted to make this a quick review. So after we do repeated dosing, of any scheduled medication, it generally takes around 3 to 5 half-lives to reach steady state. And this is important to keep in mind because that will impact how long we want to have a patient on a consistent dose before we adjust any dosing. That way we can know that patients are on a stable level before we make any dose adjustments. Versus if we made adjustments too early, we would be increasing this amount of drug a patient may get before they achieve steady state. And so since this is dependent on half-life, we want to keep in mind that medications that have longer half-lives mean it will take longer for us to achieve this steady state. So now getting into the meat of the topic, which is doing methadone conversions. We always want to remember that methadone does not have a linear conversion ratio. So if we kind of touch back onto our last session, we talked about the benefits of methadone, right? It has similar mechanism of actions to SNRIs and TCAs with the impacts on serotonin and norepinephrine, which may contribute to neuropathic pain components. And then the biggest thing is this NMDA antagonism, where it may help with opioid tolerance if patients are having hyperalgesia, and also providing neuropathic pain components or management of neuropathic pain. So because of all these factors, it isn't going to be a clean linear conversion, and it will be dependent on how much opioids a patient is currently on and doing this conversion. So if you do literature searches and seeing different institutions, what conversion factors are available, there's a lot of them. And so in 2019, a group of palliative care experts kind of came together and made a white paper consensus in regards to safe and effective management of methadone. And they're also utilized some of the information from the American Pain Society in creating this consensus paper. So this is what we'll be primarily talking about, and it is a nice conservative conversion ratio, and it is very simplified versus some other conversions that may be kind of floating around out there. So the next thing, or the first thing that we want to do before we go into doing converting of methadone is we want to determine how much opioids is the patient using, and then determining how much do we want of that daily total as a basal amount, meaning long acting, something that's kind of more constant and treating the pain more consistently, and in hopes of reducing the amount of breakthrough doses or SOS doses that patients may need. So in hopes that they may not need to take the medication every 4 hours. But when we start this, we will be doing more conservative ratios. So we do want to make sure we're supplying our patients with sufficient amount of SOS doses or as needed, just to make sure we can cover them, because we want to wait until they achieve steady state before we make any dose adjustments. So with this white paper consensus, there are two major categories, which is determining if your patient is opioid naive versus opioid tolerant. And typically we define opioid naive as any patient that's using less than 60 milligrams of oral morphine equivalents a day. And any higher than that, for at least 7 days, we typically consider that as opioid tolerant. So when we look at patients that have not been on many opioids, the consensus is it would be reasonable to do initial dosing anywhere from 1 milligram every 12 hours or 2 milligrams per day in total, up to 2.5 milligrams every 8 hours. So a maximum of 7.5 milligrams a day. And I want to note that because remember we talked about analgesic duration is anywhere from 8 to 12 hours. So methadone should be dosed in these timeframes of every 8 hours or every 12 hours. So once a day dosing may not be sufficient to cover for pain the whole 24-hour period. And when we decide what would be a good dose using this initial dose range, that doesn't provide clear guidance, but we do want to keep in mind what is our population or what is the patient that we're treating. If there's someone that may have a little bit more concerns of hepatic impairments, or if our patients are older or more frail, you may want to err on a little bit more of that conservative side of starting 1 milligram every 12 hours. And then we can monitor and titrate up as needed. And then now jumping on to our more opioid tolerant patients, when we talk about this population, and which will likely be a lot of patients when we're considering methadone, we want to break down how much opioids are they currently needing in their OMEs, and then also their patient's age. So the key things to note is the recommendation is if patients are using anywhere from 60 to 199 milligrams per day of oral morphine equivalents, and they are less than 65 years old, then we would do a conversion of 10 to 1. And when we do this conversion, this is a one-way conversion. It never goes back to the other way around. So it's always morphine to methadone. And for patients that are using 200 milligrams or more of oral morphine equivalents, or they are 65 years and older, then you would want to use this more conservative conversion ratio of 20 to 1. And the key things I want to note is and or. These will be very key on making these decision-making for our patients for this conversion ratio. And in the event that patients have very high opioid requirements, the general recommendation with the HBC consensus white paper and also APS is that the maximum initiation dose, regardless, should be 40 milligrams per day. This conversion ratio actually includes the factor of incomplete tolerance. So you don't need to further decrease because you're doing that switch of opioids. When we do titrations, the general recommendations for increasing or decreasing a dose is going to be dependent on what dose the patient is currently on methadone. So if we determine that the patient is on a stable state or steady state and they may need a higher dose, the maximum you want to increase is by 5 milligrams a day. If they're beyond this 30 milligrams a day dose, then you can go as aggressive as 10 milligrams a day increase. But when we're trying to decide how long should we wait for steady state, things to keep in mind is if patients are having generally normal liver function and we're not concerned about this, then we don't want to make any dose adjustments any sooner than 5 to 7 days. If there is concerns of hepatic impairment or patients are elderly, then we would want to kind of be conservative and assume they may have slower metabolism. So we want to wait 10 to 14 days before making dose adjustments. And last session, we kind of talked about drug interactions. When we start any inhibitors or stop an inducer of these CYP enzymes that are moderate or major interactions, then we will want to empirically reduce the dose of methadone because we anticipate whenever we do this, it may cause an increase of methadone accumulation. So we want to empirically reduce methadone and monitor carefully. In the other end, when we're stopping an inhibitor or we are starting a new inducer, we would think this may cause methadone levels to actually decrease. However, it's not predictable, so we generally err about leaving the dose the same and monitoring carefully for if there's any increased pain or withdrawal symptoms and providing adequate breakthrough dosing. And if the patients are consistently on these medications or it's unavoidable, then you can titrate as needed, but keep in mind that you should be conservative. And so with these drug interactions, There's actually a very nice resource called the Flockhart table. And I believe this is from University of Minnesota. But if you go onto this link, and I believe the slides will be shared with everyone, it has a very nice graphic table with lots of drugs and all the interactions. And you just need to keep in mind which SIPs that we're worried about. And then another resource for QT prolongation drugs is credible.meds.org. And you can search up any medication and see what QTC prolongation risks are associated with that medication. And so I'm going to turn it back to Dr. Sunil now, and then afterwards we'll go on to the cases about everything we've gone over so far.
Thank you, Theo. I would now like to ask, you can ask any doubts if you have that Theo have gone through this time.
In the titration for 10:1, you mean that suppose the patient is taking 60 milligrams of morphine, that means 6 milligram of methadone should be given daily. That is what is meant by that?
No. Suppose the patient, actually, according to the white paper consensus, if the patient is taking less than 60 milligram of oral morphine, you can start anything between 2 to 7.5 milligram per day. Okay. But if the patient is taking 60 milligram to 199 milligram, then the conversion ratio, and if the patient is below 65 years, conversion ratio is 10:1. That means, suppose the patient is taking 90 milligram, 90 milligram of morphine. Then if you want to convert it to methadone, you have to divide it by 10. So 90 divided by 10, because that conversion ratio is 10:1. So 90 divided by 10, that will be 9 milligram of methadone. So you can start 4.5 milligram BD. Yeah. You
9
can see here.
milligram 9 milligram in 24 hours as BD
Yes,
goes.
24 hours. Yeah.
Okay, thank you.
And I would say to keep in mind that when you do these conversions, you want to do a conversion of how much you would want to use as a basal amount. So typically, you don't necessarily want to convert 100% of the opioids that patients are requiring into basal. You can be as conservative as 50% or as aggressive as 75% as my rule of thumb.
Sir, what about the breakthrough pains or any activity associated pain? So in case of morphine, we give a supplemental dose prior to activity. So in this case, what should we do if the patient is on methadone?
Yeah, so if patients are having breakthrough pain, you can continue them on their immediate release medications. A general rule of thumb is 10 to 15% of their total opioid requirements every 3 to 4 hours. So you can continue the morphine SOS as needed or as needed.
Thank you, sir.
So Theo, there is another question. Can methadone be started as first-line drug of choice?
So it can be started initially on patients if you think they would be a good candidate. And you think that they may need a long-acting medication. But I would always say to keep in mind what are the risk factors and would they be a good candidate. But oftentimes, if you are suspecting lots of neuropathic pain components, it would be a good option. So like head and neck cancers would be great.
Suppose a CKD patient stage 4 or stage 5 in severe pain, so we can straight away start methadone. Is it possible? That's the same question I'm asking.
Yeah,
CKD.
so for CKD, end-stage renal disease, methadone is great because we don't have to be concerned about renal function because a lot of the clearance is through the bile and hepatic metabolism.
Okay, thank you.
Sir,
as far as my knowledge is concerned, methadone as the first line of treatment maybe it should not be started, beyond the 65 years old. Is that a concern?
Sorry, your sound is breaking. I couldn't hear it properly.
Am I audible, sir?
Voice is breaking, but please speak.
I wanted to know whether we can start methadone as a first line of treatment in more than 65 years old patients.
Okay, Thea, the question is whether we can start methadone in patients who are over 65 years of age as a first line medication.
So if we think that methadone would be an appropriate medication, then yes, you can start it in patients over 65. I would just err on conservative dosing and waiting sufficient time. So maybe towards the 10 to 14 days before we do dose adjustments, just because we anticipate they may have slower metabolism. And if they're on the opioid naive end of their requirements, then I would probably start them on 1 milligram every 12 hours.
Regarding the conversion, I also found another table which says like you convert to oral morphine total dose. I mean, it's always a two-step. So if it is below 100 milligram, it is 20 to 30% of methadone dose split into BD. If it is 100 to 300 milligrams of oral morphine, it is 10 to 20%. And 300 to 600 is 8 to 12 and so on and so forth. Is this table also applicable or only the white paper, whatever you explained now?
Dr. Harimohan, so there are many methods for conversion of oral morphine into methadone, and previously we were thinking what to use, which conversion method to be used, but now because this white paper has come into action, we normally use white paper consensus method, so we don't use any other methods now.
Yeah,
because this is very simple and safe.
Yeah, I understand, Dr. Sunil. I was just calculating both, but in the white paper, it comes a bit low. I felt, I don't know, if I could be wrong, is it the dosage will be a little more low, like if you calculate?
Yeah, there will be some differences between two, but yeah. I think from my experience of using both, I think white paper consensus method is better.
Wonderful. That's fine. Thank you.
Yeah, so these conversion ratios are going to be, this conversion ratio can be a little bit more conservative versus some other ones, but keeping in mind that methadone conversion is not linear. So we can always dose adjust. And from my experience of using this, in addition to Dr. Sunil's, we've had a lot of success with this.
Sir, one more doubt. If patient is on methadone, suppose 3 milligram Q8 hourly, what will be, and patient is having breakthrough pain, what will be the morphine dose for that breakthrough pain?
So it will, oh, sorry, go ahead, Dr.
Theo, you can go.
So it will be dependent on what their total opioid use was before. So actually, let me do just quick math. So I'm assuming if you did that ratio and they were on 9. So if this was someone that was less than 65 years old and they, I'm assuming were on maybe 90 milligrams of oral morphine per day, and we added it, or a little more than 90, and we added on this methadone. If we estimated they had maybe 100 OMEs, then you can do a morphine dose of 10 milligrams every 4 hours as needed. But I'll go over breakthrough pain doses during the patient cases.
So I hope you understood what Theo told.
I need more clarification.
Okay,
So
so
I also
9 milligram means so you might have converted it from morphine to methadone. So what should be the morphine dose for that total daily dose of methadone? 9 milligram. So if the patient is less than 65 years,
90.
then 90 milligram. So 90 milligram
Yeah.
divided by 10, it is 9 milligram. So usually the dosage of morphine should be 15 milligram Q4H. So that will be 90 milligram per day. So the SOS dose can be 10 to 15 milligram Q4H SOS.
Okay, sir. Okay, thank you.
So how is the, I mean, how many breakthrough do you increase the dose? Is it the same three? When do you increase the dose of the methadone? If you are giving more than 3 breakthroughs?
Yeah.
So,
yeah.
Yeah, so it's going to depend on how much you think that is acceptable for the patient. So if a patient is still taking their medication around the clock, I would consider starting to add some of that SOS dosing, a portion of that towards into the methadone for that basal, so they don't need to take it as often. Typically, I think if a patient's doing anywhere from 2 to 4 SOS dosing, that might be okay. Any more than 4, I think that might be very burdensome for the patient to need to take so much. And also keeping in mind, are they able to even get a full night's sleep?
Any more questions?
Yes, Dr. Sunil. I have one question here. I'm Dr. Nivedya. Just
Yeah.
wanted to know, when you increase the dose of methadone, as Theo said, like as Dr. Hari had told, if you have a lot of breakthrough pain and you are going to increase the methadone, how do you increase it? Do you increase it by 0.5 milligrams every day over some time and wait and watch, or how do you do that, sir? Just wanted to know, how do you increase it?
Yeah, okay. So as per this consensus white paper, it says if the patient is taking less than 30 to 40 milligram per day, you can increase 5 milligram every week. But if they are taking more than 40 milligram, then 10 milligram per week.
So can you please repeat it once?
If the patient is taking 30 to 40 milligram per day, and if you think that this patient need to be increased the methadone dose, then increase 5 milligram. And if the patient is taking more than 40 milligram per day, increase 10 milligram. But you have to understand that when you increase 5 milligram, you should not increase 5 milligram every day. You should increase 5 milligram and wait for another 5 to 7 days for methadone blood levels to be stabilized.
Can you repeat that, Dr. Sunil? Sorry. Can you repeat that again?
If the patient is taking less than 30 to 40 milligram per day, and you think that this patient needs methadone to be increased, you can increase 5 milligram per week. Means today you increase 5 milligram and then wait for another 5 to 7 days for further increase. And if the patient is taking more than 40 milligram, you can increase 10 milligram.
So is it like increasing 1 milligram per day at wait?
No, Sangamitra, you can increase 5 milligram itself.
So we increase 5 milligrams at one go, and we wait for that to stabilize for another 5 to 7 days.
Yes, that's correct.
And what about the breakthrough pain which comes within these 5 to 7 days?
Yeah, you can use the morphine for breakthrough pain.
In the equivalent dose of 5 milligrams or the other
Uh,
dose that has already been started?
no, actually, the previous dose, and you may need to even increase the dose little bit.
Okay.
But it is
Okay.
always safe to use the previous dose of morphine.
Yeah.
Okay.
So I'm wondering if it's okay with everyone if we go a little bit out of order and I go over the cases now, since I'll be going over a lot of the questions that everyone is having right now on the calculations.
Okay, just I
Okay.
think that's a good idea, and just giving you time check. It's 7:31. Half an hour is done.
Okay, Theo.
Yeah, so I'll go over this and then Dr. Sunil can go over some of his past experiences after we go over the cases. I forgot I was muted. So for this case, we'll be using the same one as the last time, but I've simplified the case, took a lot of the contraindications out, and let's just assume this patient is a perfect candidate for methadone. So we'll kind of jump through the details. So last time it was a 57-year-old male with stage 4 pancreatic cancer with Mets to spine and liver. And he has uncontrolled pain in his back and legs. We don't need to go too much into the details since we went over it last time, but some of the analgesic history that the patient had was gabapentin, ibuprofen, gabapentin. He didn't note much pain relief from this, and they've gone as high as doses of 1,800 milligrams per day, and it really just caused sedation. The patient has taken ibuprofen in the past and had mild relief, but was told to stop because his kidney function. Amitriptyline they tried in the past, but the patient could not tolerate the side effects of dry mouth and had some mild confusions. They already did a 5-day burst of dexamethasone with minimal relief, and the patient could not afford a fentanyl patch. So the pain that they had was back pain that was described as sharp, burning, achy, and it was severe as a 9 out of 10, and the lowest it's ever been was a 7. And the other pain that they had was pins and needles with numbness, but also a feeling of sandpaper rubbing with any sense of touch. So kind of signifying our concern of maybe they're having hyperalgesia. And then severity is 2 out of 10 and 5 out of 10 at worst. So going on to the medications. So with this simplified case, the patient's only taking hydrochlorothiazide, 25 milligrams POBD, insulin, paracetamol, and then for morphine, they're currently taking 60 milligrams PO Q4 SOS. They report that they need 6 doses a day. Sometimes the pain is so bad, they add on an extra dose to 7. So what would you want to initiate for methadone, and what is your recommendations? So kind of what we talked about earlier, the first thing that we want to do is we want to make sure that we calculate how much oral morphine equivalents that patient has been needing every day. So with this calculation, they are consistently using 6 doses a day. So that would be 360 milligrams of oral morphine per day. The next factor is how much of this do I want to convert to the basal opioid? And so looking at their pain severity, you can recommend anywhere from 50 to 75% of this daily oral morphine equivalent use to basal. In this case, the patient's pain is not well controlled at all. It's 9 out of 10. The lowest it gets is 7. So let's use that 75%. So if we do that, we're going to anticipate maybe we'll want to move 270 milligrams of oral morphine equivalents into this methadone. So based on this case, what conversion ratio would everyone want to use? It's a 57-year-old male, and he's using 360 milligrams OME. And then we're planning to convert 270 OME to basal.
10:1.
So that is a good point because the patient is 57 years old. However, if we go back to that conversion ratio, the patient falls in this category of 65 years and older, but their OME use is over 200. So remember, I tried to emphasize this and or aspect. So because they hit one criteria on this more conservative conversion, we would go ahead and use this 20:1. So now kind of moving forward with the math. So we're going to use that 20:1 conversion ratio. So dividing by 20, we get around 13.5 milligrams of methadone a day. So remember that the analgesia lasts 8 to 12 hours. So we want to dose based on that frequency. And then the final methadone regimen will be dependent on the formulation that's available. So if you have liquid, you have more freedom on dosing. But in this case, I'm going to pretend we have the more complex case and we only have 5 milligram tablets. And this is sometimes more of the problem that I face. So whenever you're trying to fit a regimen to what your patient may need, I always go conservative and round down, because remember, we can always wait and add more later and get them to a good dose, versus if we overshoot, then we can't take back. So in this case, I would round down to 10, and then I would start our patient on the methadone 5 milligram tablets, 1 tablet by mouth every 12 hours. So that would be a good starting point. And then we can have them on this dose for 5 to 7 days, see how they're doing and how much breakthrough dose they need, and adjust. So the next question everyone had is, well, what do I do about breakthrough dosing? And that's a great question. So, okay. So when we think about how much SOS dosing they're using, if we continued the 60 milligrams a day, that might be too high of a dose, right? Because we're adding on a basal and on this 60 milligrams a day that they're already currently taking with some relief. So the rule of thumb that I generally use is you can use an estimate of 10 to 15% of total daily OMEs. So if we keep in mind they used 360 in the past, we can use 10 to 15% as breakthrough dosing. For this case, because we used 75% of their OME, I err a little bit towards the conservative side, but it wouldn't be unreasonable for you to use that 15%. But in this case, I calculated 36 and I'm rounding their SOS dose to 30 milligrams. So is this going to be enough? So let's kind of back calculate. If we use 30 milligrams and we're saying Q4 hours SOS, that would mean they can have 6 doses a day. And then if we calculate that, then the patient can have up to 180 OME in addition to the methadone, right? And we use 270 milligrams OME as that basal conversion. So we are supplying the patient with enough, likely to kind of cover them until we can start increasing their methadone dose if needed. So with this case, the final regimen that I would consider is methadone 5 milligram tablets by mouth every 12 hours with SOS dosing of 30 milligrams every 4 hours as needed for breakthrough pain. So then we can monitor in 5 to 7 days and see how much SOS dosing they're still needing. So follow-up. So the patient's notes that the pain has slightly improved. They note their pain was previously around 8 to 10, but it's still controlled. Right now it's 6 out of 10. They would like to have their pain a little bit better controlled. How would we adjust their dose? So the patient reports that they're taking 6 doses of the 30 milligrams morphine SOS, in addition to that new methadone dose that we did. So what would we need to do? So we want to calculate how much SOS dosing are they using, right? So if they use 6 doses of the 30 milligrams morphine IR, then that would be 180 OMEs. We want to make sure when we're doing this evaluation, the patient has waited sufficient time to reach steady state. In this case, the patient was, and this is actual doses that they took. And so in this case, the patient was 57. They have normal liver function. So 5 to 7 days would be sufficient time. So now we want to determine how much of this SOS do we want to convert into the basal. So you can be more aggressive, or you can choose to maybe let's add half of this IR into this basal and see how they do later, right? So if we chose to do 50% of that, that would be around 90 OMEs. And if we use the same conversion factor, 1 to 20, then we would calculate 4.5 milligrams of methadone a day. So that's how much I would want to increase. And keeping in mind, because they're using less than 30 milligrams a day, this falls within our maximum increase range. So rounding this tablet size, I think that's reasonable to just make it 5 because it's a small increase. But I would recommend to do the 5 milligrams every 8 hours, and then we'll reassess. So there's a question from Dr. Kulkarni. If we are giving morphine 6 times a day in renal insufficiency case, why not just manage with morphine anyway, rather than adding methadone and making it complex? That's a great question. So if we're using morphine and oftentimes we're worried about toxicity with renal insufficiency, we want to keep in mind that patients may not have immediate side effects of the toxic metabolites that can lead to myoclonus. It will take time and they may continue to build up on that. And also, if we use methadone, we can kind of reduce that burden of morphine that the patients are needing to take to reduce this risk of side effects. And actually, because it has that NMDA antagonism, we may actually have a lower amount of opioids they're requiring because we may impact their opioid tolerance. And then the other aspect is the patients will not, once we get to a stable dose, they may not need to take that morphine every 4 hours. They may need to maybe take it less frequently. Thank you for that question. That was a great question. Okay, so the next case we're going to talk about is what if our patient that we were talking about earlier needed to be on fluconazole. And it was unavoidable. This is the only medication option they can to treat an infection. What would we need to do then? And this is the case where we're pretending we never started methadone yet, and this will be a new start. So we want to keep in mind that fluconazole is a moderate CYP3A4 inhibitor. And when we talked about the drug interactions, this is one of the CYPs that we're worried about. So remember, when we start an inhibitor or stop an inducer, we want to empirically reduce methadone by 25 to 33%. This also applies to new starts. And we want to be conservative because we don't know the exact amount how much methadone is going to be increased from this drug interaction, but this is more of a practice example that we utilize. There isn't hard evidence to say you have to do this, but this is more of a rule of thumb practice, just to be more conservative. So if I was doing our patient who we were going to convert 270 milligrams of their OME use to basal, I would have that 13.5, which we discussed earlier, but I would further reduce by that 25 to 33%. So this would lead to 9.1 milligrams. So I may be more conservative and round down to 7.5. And that's because I'm keeping in mind that I have 5 milligram tablets, and the smallest I can do is break in half. which is 2.5. If you have liquid, you have a lot more freedom for that. So in this case, I would recommend 2.5 milligrams of methadone every 8 hours, in addition to our SOS dosing that the patient may need.
So Theo, another question from this would be, the patient is on fluconazole and you have reduced the dose of methadone. Suppose the treating team want to stop fluconazole, and then how do you go?
So the other way around is if they've been on the fluconazole and we started methadone and they've been on the methadone for, let's say, a week, I would keep the methadone dose the same and wait another at least a week, at least 7 days, and see how they're doing. Because remember, when we stop the inhibitor, we anticipate the methadone dose may decrease, but we don't know by how much. So the one thing we can anticipate is they may have more pain. There could be some withdrawal, but we don't know exactly how much that is going to be. So we want to make sure we supply our patient with sufficient SOS dosing to cover them until we know they're back at steady state with this new drug change. And then we can kind of go from where we would normally again.
So we had earlier discussed regarding the BD dosing, but in the two examples we discussed, we had converted to 8-hour dosing. So which way to choose, 8-hour dosing or dosing 12 hourly?
You can do either one. And the main reason why I did the 8-hour dosing is because that's the closest I can get to 9.1 milligrams. So if this was 10 milligrams, then I would do 5 milligrams twice a day. So I adjust it based on what formulation I have. And sometimes if patients say the methadone only lasts 8 hours or 10 hours, then I might try to do every 8-hour dosing. But really this 8 to 12 dosing is just based on whatever tablet size might fit. But again, if you have liquid, you have a lot more freedom. And I'm just choosing the more complex cases so we can go over all of these questions. So I'm glad everyone is asking all of these.
Thank you, sir.
Okay, so the next special case is, let's say we have a different patient and they were requiring a massive amount of opioids, and we decide we need to convert 1,200 milligrams of morphine to methadone. So if we did this calculation and did the conservative of 20 to 1, and we get 60 milligrams of methadone a day, what dose would you recommend?
Anybody?
Again, on the how much pain relief he is having, will be converting basal dose as 50 to 70% of the 60 milligrams.
So let's say we did all of that and it ends up being 60 milligrams. What regimen would anyone start? Q12, Q8, what dose?
The 8-hourly regimen will probably allow for a lower dose to begin, then a higher dose in a BD. So probably a 8-hourly regimen.
Yeah,
better to start.
Yeah, so we can use any 8-hour dosing or 12-hour dosing, but the key caveat we want to make sure we don't forget is, regardless of conversion factor, maximum dose we want to initiate methadone is 40 milligrams.
Yes, thank you.
And this was maybe a little unfair question, but I figured this is important to point out, which might get overlooked until this. So remember, even if we calculate 60 milligrams of methadone a day, we don't want to do more than 40 milligrams in a day, right? So if I had 40, I would probably do 20 milligrams twice a day. That should be a good starting point, and then we can start titrating once we have sufficient steady state time.
So in that case, don't you think there'll be, inappropriate pain management of the person, of the patient, if we start only on 40, but the requirement is 60?
So, so the main reason why the recommendation is this is because, remember, methadone is not a linear conversion, and there may be, because of that NMDA antagonism, reduced tolerance, so their requirements could go substantially down. And so we don't necessarily know if that is going to be enough, but again, we can always start to go up. If we are going down on this decrease, we just want to make sure, are we providing enough SOS dosing to cover our patient's pain until we get them on something stable?
Yeah, thank you, sir. Thank you.
Okay, so the next one is, what about an opioid naive patient? So let's say we have a 35-year-old female that presents with metastatic head and neck cancer for pain management. She was determined to be a good candidate for methadone, which might help with her neuropathic pain. Pain's currently a 7 out of 10. She's currently taking morphine IR 7.5 or half a tablet every 4 hours as needed for breakthrough pain. She reports needing to take 6 doses of 7.5 SOS. And so when we do that calculation, we get 45 milligrams OME per day. Past medical history includes CKD, hypertension, type 2 diabetes, and head and neck cancer. What methadone dose would you start?
40 milligrams, just like the previous example.
Does anyone else have a calculation?
20 milligrams BD.
So, so what conversion ratio were you using for the 45?
1. 10:1.
10:1.
10:1.
4.5.
So that'd be 4.5 a day. So if we think about that, on opioid naive patients, we can start anywhere from 1 to 12, or 1 every 12 hours up to 2.5 every 8. So any dose in that range would be reasonable. But one thing I like to do is I still like to kind of play around and use that conversion ratio, just so I feel this will give me a better kind of guess of what might be an appropriate dose. So if we use this patient case, she's less than 65 years old. She's definitely using less than 60 milligrams. So we can be a little bit more aggressive with this dose conversion, and we would get 4.5. But if we're rounding up, I think that's reasonable, because 2.5 every 12 would still be in this safe opioid naive range. So that would be a great regimen to start. And again, the pain may not be controlled, or the pain could be controlled. We just have to monitor and give sufficient time for the patient to achieve steady state. So discussion points on all of this is determining if patients are good candidates, evaluating their total OME requirements and factors that might impact their pain, and methadone conversions, dosing, and titrations. So age, hepatic function, drug interactions, etc. Methadone does not have linear conversion factors. We want to allow for a sufficient time for patients to receive steady state before adjusting doses. So typically 5 to 7 days, but again, in advanced age over 65 or hepatic dysfunction, we may want to be more conservative and wait towards that 10 to 14 days, because we anticipate there is probably reduced metabolism, then making a longer half-life. Therefore, the steady state will take longer. And then when we discuss this conversion ratio is only from morphine to methadone. And then don't forget to add on bowel regimens for constipation, since methadone can still contribute to constipation. Okay, and then I will open this up to Dr. Sunil.
Any doubts? Anybody want to ask any doubts? Yeah.
What is the time of administration of methadone? Before food or after food, or early morning or before bedtime? If it is in BD dose.
The patients can take it with or without food.
If you give it twice a day, maybe 8 a.m., 8 p.m. would be enough. And if you give 3 times a day, then 6 to 10. And you can relax 6 and 10 little bit.
One doubt I couldn't understand one point that was discussed in one of the cases. The total morphine dose was 360 milligrams per day, and 75% of that was made the methadone dose. How is that the percentage to be calculated?
So was that when we decided to use 270? So in that case, we used that because we were planning to determine how much of the current opioid use that they need into the basal amount, meaning that long acting. So we don't necessarily always want to add 100% because that could be too much. So going a little bit more conservative to 75% is probably where I would go, and then providing SOS dosing, and then we can adjust as we move forward.
Oh, okay. Thank you.
Oh, so Dr. Broderick mentioned, so there was a question in needing what dosage form is methadone available in, liquid or tablet. And Dr. Broderick mentioned from Dr. Sunil that currently pills are in short supply. So liquid syrup is the primary formulation, which comes in a concentration of 5 milligrams per 1 ml. So because you have the liquid, you have a lot more freedom with getting your doses closer, which is nice. The most important counseling point is showing patients how much they need to take or how much they need to pool. So I always recommend patients on liquid methadone should have an oral syringe to use so they can measure, and then maybe marking that line of where they should be pooling to, so patients don't get confused and maybe pool too much.
So what about rectal methadone, Theo?
Yeah, so with methadone, it can be given rectally. And typically, if you are going to administer rectal methadone, I would always use the liquid formulation and not a tablet, since the tablet may not absorb well. But rectal administration will still have good absorption.
So I have used it for one patient, our team, and we have administered the syrup itself, and it has the same effect as oral methadone.
So for the basal, the question is,
yes, morphine.
Oh, sorry, can you ask that again? I didn't hear.
Is it constipating as like morphine, or or least constipating?
I don't know the
Methadone.
exact numbers, but I would anticipate to just treat it very similarly as just an opioid class effect, that it is going to be constipating. So we want to make sure we're proactive and add a bowel regimen.
One thing is that when you convert the patient from morphine to methadone, um, the receptor effect in the gut due to morphine will be released, and then at first there can be a diarrhea or loose stools. Then it will be same as that of morphine. Means of it will also produce constipation. But at first, maybe first 2 days, the patient can have some loose stools because of the
Dr.
release.
Sunil, Dr. Sunil, regarding the rectal installation, how do you do it? How much inside? You use a syringe, or what's the method of giving a rectal? Because it's going to be a very small quantity of 1 ml sometimes. So how do you do it?
Either you can use a small syringe, 2 ml syringe, or what you can do is take a scalpel and cut it from the hub and just put the tube alone and just push 1 ml into the rectum.
So can we crush the tablet in and make the saline formulation?
So if you do not have, sorry. So if you do not have liquid available and you need to crush the tablet, you can do that. But the one thing I wouldn't do is I would only crush it and mix with liquid right before administration, because if you're putting the tablet in water, I don't know what the stability would be. So I would not crush tablets and leave it in a bottle for long-term use. It should be crushed for as needed use. But if you do need to use liquid, then I would always advise to use that formulation.
Thank you, sir.
Is there any contraindication to use this methadone?
Sorry, I didn't hear that.
What are the contraindications for using methadone?
Okay, so the last session, we went over a lot of the contraindications. So if patients have a family history of sudden death, that might signify they may have history of like congenital QT prolongation. If they have a documented history of congenital QT prolongation, if their QTC is over 500, and then if they, not necessarily contraindication, but if a patient has difficulty with following up with appointments, or there's no way to for the patient to have access to care sufficiently, and there's no caregiver, especially if they have trouble with following directions with taking medications consistently, then they may not be a good candidate.
Okay.
So some of the questions on the chat from Deepak is, are basal amounts taken at 75% for calculations, or at least a rule of thumb? What would be some of the other factors to be mindful while converting to basal? Yeah, so that 50 to 75% is kind of my rule of thumb of being more conservative. I am more conservative if their pain is well controlled. So I may err towards 50% of that. So if a patient's taking their morphine SOS every 4 hours, but their pain is good and well controlled, then I would probably err towards a little bit more of that conservative. Versus if their pain is not well controlled, I'll be a little bit more aggressive. But it is a rule of thumb. It's not a hard defined rule.
What about breathlessness? Can we use it for breathlessness also, as we use a low dose morphine?
So in regards to breathlessness, I know most of the data is using low dose morphine. I don't know if there's evidence to say that methadone is more efficacious, but if they're needing to take the low dose morphine consistently, then it may be reasonable for that to be more of a long acting, but I actually don't know if I can speak to that. Maybe Dr. Sunil, if you know.
I had one patient who had actually allergic to morphine, and the patient was suffering from cystic fibrosis, interstitial lung disease, and then she needed an opioid and started on low dose methadone. So I think we started on 1 milligram BD. That patient had good control of breathlessness.
Thank you, sir.
Yeah, and just to emphasize, methadone should not be used as PRN or as needed or SOS. This should only be as a scheduled dose. And then one question is, does methadone have interaction with Ayurvedic herbal preparations? I don't know which plants or herbs are in the preparation, so I don't know if I can speak to that, since it'll kind of depend on what is the chemicals or compounds in the plants that are being used and if they may cause CYP interactions. So I would say that would depend specifically on what plants are used and if that does cause CYP interactions.
So would you recommend more methadone to be used for home care patients, those under home surveillance?
Yes, Sangamitra, we are using methadone. We use during our home care, and we start during home care.
How much would be, how would you monitor actually? Because
We actually, after starting, the nurse will follow up the patient at least for 1 week closely. So that's how we usually monitor the patient, and maybe after that you can reduce the frequency a little bit, and once maybe after 2 weeks, then you can have more freedom.
Hello, Dr. Sunil.
Yeah.
Yeah, now I had asked a question about the Ayurvedic preparations. Actually, in a country like India, you see many people, they think that Ayurvedic and herbal preparations are very safe, and they don't even inform us when they are using them. So should we tell them not to use those preparations, or be very careful while giving methadone for home care? Because we don't even come to know if the patients are having such products.
That's true, and I know that Theo Kashel was talking about there are many interactions with Ayurvedic and homeo medications, but what all plant products we don't know. So better if we give methadone, maybe you can try with Ayurvedic medication and even with a lower dose of methadone than the calculated dose. And then to increase. Otherwise, you have to ask the patient to stop it.
I usually ask them to stop it.
that's when the patient actually runs away from you, I think, when you ask them to stop.
Yeah,
I think that's their problem. We have to be very, we have to practice something with certain firmness, as simple as that. You want to take this, you better stop that. Don't come back with any toxicity to me.
So,
Theo.
So I would say that if patients are very attached to their Ayurvedic medications, and that's something that they won't budge on, and that's a deal breaker for them, I think as long as they stick with something consistently, there could be CYP interactions. So I would say, and if it's like no possibility for them to stop, you probably can start methadone as, because if you deem that the benefit outweighs the risk, there could be some CYP interactions where they may have less metabolism of it. So you would want to start on more conservative doses and consider going up much more slowly than you would in a patient not taking Ayurvedic medications. But this is in the event that patients are very attached to it, but you still think patients still need pain management and the benefits will outweigh the risk. So we just want to be cautious.
So in India, we have only one manufacturer for methadone. It is Rusan, and Rusan Pharmaceuticals. And in Kerala, only one agency, that is Shabri Agencies in Kochi. They are the supplier.
Dr. Sunil, can you speak to the availability and whether the scarcity is a permanent problem?
Yeah.
Or
So as of now, we have a shortage of methadone tablet, and the expiry of methadone is in this month, tablets. So they are planning to come up with a new batch in June, I think. But the expiry of syrup is till 2022 September, I think. So syrup is available, but if you apply, it will take some time, maybe some 3 weeks to get it.
So we have to get the drug controllers sanction. Am I right?
No, actually, if you have the RMI license, that is recognized medical institution status, you can apply to the agency. No need to get any extra license from the drug controller.
Okay.
Because methadone also come under one of the essential narcotic drug, END. So we have total 6 ENDs in India. So codeine, hydrocodone, oxycodone, methadone, morphine, and fentanyl. So these are the 6 essential narcotic drugs which will come under the RMI.
What's the size of the bottle? Is a big one, or it can be when we want to dispense it? The how much? What's the quantity?
It's 150 ml. 150 ml.
So dispensing may be a problem for from such a big bottle.
It's not a big bottle actually. It's a small bottle, only 150 ml. But previously we thought it is a small bottle and we were giving 150 ml to each. But because of now scarcity of methadone syrup, now we see that it's a big bottle, and now we don't give a full bottle to patient.
Dr. Sunil, can you answer the question? Would you start a antiemetic for the first 3 days of methadone as many do for morphine?
Antiemetic.
So I would say only if the patients do have nausea. The one concern is the most common antiemetic being prescribed is ondansetron or Zofran. So we have to keep in mind that has an additive QTc prolongation risk with methadone. So that may have additional risks that may outweigh the benefit.
So usually most of the patients will be converted from morphine to methadone. So in such instances, you need not have an antiemetic because the patient's body is already exposed to an opioid. So the chance of nausea and vomiting is very less. But if you are starting the patient on methadone, then when the patient is exposing for the opioid for the first time, then there is a chance of nausea and vomiting in about 1/3 of the patients. So maybe you can give antiemetic. We give metoclopramide, and I see that domperidone is more problematic than metoclopramide.
If you have license for keeping 500 grams of morphine, how much methadone can we stock?
There is no such rules. You can get it. I think if you are getting methadone for the first time, maybe you take some 1000 milligram of tablet and 5 bottles of syrup. Take less bottles because most of the patients would like to take tablet because it is easy compared to syrup.
Actually, we are using only morphine, not methadone so far. That's why you're asking.
Yeah. Yeah. So Sangamitra is asking any interaction with dexamethasone. So actually dexamethasone will decrease the dose of methadone as per theory, but in practical terms, maybe if you start steroid along with methadone, maybe some anti-inflammatory effect will also help to reduce the pain. So we don't use, yeah. No interaction with steroids?
Excuse me, I was correcting myself on the chat after you said that. So excuse, I just wanted to defer to you, Dr. Sunil, excuse me.
Okay.
Dr. Sunil, I have a question.
Yeah.
You have a checklist before you start methadone, like this patient. Have you got a formatted checklist in your hospital? Do you do something like that? Is it
Yeah.
worth doing that?
Yeah, we have.
What about the using of SSRI, SNRIs, and antidepressant TCA? They all have this QT prolongation. So you're going to, will it have an addictive effect if you're going to use as an adjuvant along with methadone? Dr. Theodore?
Yeah, so with TCAs, since we're kind of aiming for the same mechanism of action with serotonin and norepinephrine, I would probably err towards kind of taking patients off of a TCA because they have much higher QTC prolongation risk for maybe not more additive benefit if we are going to start methadone. So I would probably err towards trying to take them off and then do that switch. For other SSRIs, that's not necessarily contraindicated to it, but keep in mind some antidepressants can cause CYP2D6 inhibition, meaning there may lead to higher methadone levels. And we also want to keep in mind methadone also acts on serotonin. So we want to be cautious on how many serotonergic agents we're adding on because we could put patients at risk for serotonin syndrome. So it will just need close monitoring.
Thank you.
And the question is, are you saying about ondansetron having QTC prolongation if given antiemetic with methadone? I think we usually give metoclopramide with antiemetics for opioids. So I think both medications can, in theory, cause QT prolongation. If it's absolutely necessary, then it may be appropriate. Dr. Sunil, I don't know if prochlorperazine is available in India.
Yeah, it's available.
So yeah, so one of the antiemetics that we often like to use is prochlorperazine or compazine. And that one actually doesn't have QTC prolongation risk, which is nice. But generally, I would say to really only add those medications on if it's needed for patients.
So Sunil, just to give you time check, 10 more minutes to go.
So what all would you like to discuss one or two patient stories again, or do you want to ask more doubts? Or do you want me to share our experience, our team's experience regarding methadone.
Case histories may be better.
Sorry?
Maybe better.
Experience or yeah, experience is actually case discussion. So I would like to share some of the patient stories, but I don't know whether I will confuse you because I am starting it from the first case that we have seen. So the conversion will not be the same what Theo have already told. So don't get confused. But anyway, I will show you some of the patient stories. Okay, can you see this? Can you see the screen?
Yes, sir. Yes.
Okay. So this is one of the early patient when we had methadone with us in 2018. So this patient was a young lady who had Ewing sarcoma. In 2016, she had a small swelling at sacral area, and it was diagnosed as Ewing sarcoma, and she received chemotherapy and radiotherapy. In 2018, because of pain, and they did an MRI and saw that disease is progressing with extension from S1 vertebral body, and there were also compression of L5 and S1 nerve root, and PET scan shows pleural mets. So there were no oncological interventions planned for this patient. But this patient on 20th March, the patient was on 10 milligram of morphine and amitriptyline, and they continued till 23/6 June. Uh, um, this patient was coming to us just to get morphine because she was treated by another palliative care physician. But the pain was increasing, and they consulted another palliative care physician, and he put her on an epidural and continuous epidural infusion of ropivacaine with morphine. And initially she had some relief for about 18 hours, but gradually that interval reduced, and she was receiving about 30 milligram of morphine epidurally in 24 hours. Because of poor pain relief, the epidural, along with epidural analgesia, the patient received morphine, oral morphine 20 milligram 4 hourly and SOS. And after about 2 months, the epidural catheter was removed, and the patient morphine dose was increased to 40 milligram, and the pain physician started her on amitriptyline and pregabalin. But there was no satisfactory pain relief. Patient was in severe pain. In addition, she had delirium and myoclonus. So this is the pain pattern of this patient. You can see it starts at the lower back and it goes down the right leg, and it was like burning and shooting. The pain score which has shown here is when the patient is lying down without any movement. But when the patient moves, the pain increases to 10/10. And this was also causing insomnia. So we plan to start this patient on methadone. So how much was the dose she was getting? 40 milligram 4 hourly. So how do you go about starting methadone? Gajlashmi, can you read the chats?
No answers yet, sir.
Okay. Anybody?
5 mg, 20 is full.
Okay, before starting methadone, what all have to check?
ECG, renal function.
Okay, so there was no family history of sudden unexplained death because the congenital QT syndrome can run in families. So you have to ask, is there any family history of sudden unexplained death? Okay, then this is very important. Is there a reliable caregiver with the patient to administer methadone? Yes. And because our early days, we checked an ECG and the QTC was within normal limits. And we also checked magnesium, calcium, and potassium. That was also within normal limits. So we plan to start on methadone. So this is what I think Dr. Harimohan was telling. This was the equianalgesic ratio of methadone and morphine when we started methadone in 2018. So don't place it in your mind because now we are using white paper consensus method. So this patient, because we were actually afraid to start methadone because of many drug interactions, and it can cause QT interval prolongation and even death of the patient. So we were actually afraid. So actually, Dr. Ann helped us a lot to start how to start methadone. But I think when we started this patient on methadone, she was abroad. So what we did was, uh, there are many methods for starting methadone. There were a 3-day switch method. 3-day switch method. So you give methadone, the full dose of methadone by taking 3 days. On the first day, you will add 1/3 of methadone. On the second day, you will add another 1/3, and on the third day, you will another 1/3. So total dose will be given only in 3 days. And accordingly, in the first day, you will reduce the morphine by 1/3. Second day, you will reduce another 1/3, and third day, you will stop morphine. That's how 3 days switch of morphine happens. Morphine to methadone happened. But because even we were afraid to go with that method also because this is a new thing to us. And because of the fear, we didn't follow that method also. So we find out our own method. It was not right though. So, what is the morphine equivalent daily dose? She was getting 40 milligram for hourly. So, it was 240 milligram total. So, the conversion rate as per the previous chart, it will be 8. So, patient was taking about, or the methadone dose will come to 30 milligram. Okay. But when you give when you convert from one opioid to another opioid, there is something called as incomplete cross tolerance. You should not convert whole of the opioid into another opioid. So you can reduce 30 percentage of the previous opioid. So here the 30 percentage of 30 percentage is incomplete tolerance is given as 9 milligram, and the total daily dose of methadone will be 21 milligram total. So on the day one of this 21, take it as 22.5. So 1/3 would be 7.5 milligram. So on the day one, we started with the 2.5 milligram of methadone TID, and we reduced the morphine to 25 milligram. So in the first week, the patient could sleep. And instead of day 2, we waited for another 6 days. And on the day 7, we started, added another 1/3. So it became 5 milligram TID, and we reduced the morphine. And the patient had improved pain relief. And on day 14, we converted whole methadone into whole methadone and stopped the morphine. Patient had excellent pain relief. So this patient actually was getting interventional pain analgesia even with no pain relief or very poor pain relief. And this patient was actually restricted to the room on a first floor, and she was unable to move from there. But after starting methadone, the patient came walking to our outpatient department. So even though we did conversion, which is not given anywhere, But the effect of methadone on this patient because of that neuropathic pain was very good, and she got excellent pain relief.
Sunil,
And
it is 8:30. Just reminding.
8:30. Okay. Okay. So I think we can stop. Priya, you can take over.
Yeah, I
Dr.
sorry.
Priya, before you, I'm sorry to jump in.
No issues.
Would it help the attendees to have some exercises to work at home? I'd be happy to send those to people if that would be helpful. I just wonder if they'd like to do some practice calculations themselves.
Yeah, I think that would be really great, Anne.
Okay, I'll come up with things. And then Dr. Sunil, don't we have a chart that people can maybe put on their phone? Is that something that we have?
Sorry, I didn't get time.
No, I'm sorry. Don't we have a chart that people can put on their phone so it's readily available?
Are you talking about how to start
conversion?
method?
Yeah.
Yeah, conversion. Yeah.
Okay. All right.
Yeah, we can give it.
Stay tuned. We'll try to get everybody some a worksheet so they can feel more comfortable.
Yeah, I think that would be really helpful. And thank you, Sunil and Theo, for this excellent session. I think we learned quite a lot, and we look forward to start using methadone in India, many places, because we all agree that there needs addition to morphine for severe pain relief in our checklist of medicines, and I'm sure we will get little more confidence. I think, though, as we started morphine, we need to practice it, but before that, I think, because it involves some calculations and mathematics, we need to be really correct about theory. It may take a little more time, but I guess with support from Sunil at a phone call away, we should be really starting it soon. Thank you very much. I think we'll stop here.